In many cities, you can't find a doctor to prescribe testosterone to you. What's not true is that raising testosterone is a problem. There's no point in my surviving longer in this state. Some of the benefits of testosterone happen by its conversion to estradiol. He implanted in his own scrotum a continuous reading thermometer. Porn is like something that people from my generation never could have conceived when we were teenagers looking at Playboy magazine and thinking we'd struck it rich.
Welcome back to the Rena Malik MD podcast. I'm your host, Dr. Rena Malik, urologist and pelvic surgeon. Today, our guest was Dr. Abraham Morgentaler. Dr. Morgentaler is the Associate Clinical Professor of Urology at Harvard Medical School. He is a leading researcher on testosterone with over 200 published articles and landmark articles in the Journal of American Medical Association and New England Journal of Medicine. He developed the first comprehensive men's health clinic in the United States and has authored multiple books: The Viagra Myth, The Surprising Impact on Love and Relationships, The Male Body, A Physician's Guide to What Every Man Should Know About His Sexual Health, Testosterone for Life, Recharge Your Vitality, Sex Life, Muscle Mass, and Overall Health. Today, we had an in-depth conversation about testosterone, how it was discovered as a men's sex hormone, and what exactly testosterone does for the male body. We also talked about why people are so cautious in prescribing testosterone and what myths have perpetuated about testosterone over the years. We talked about how low testosterone is linked to inflammatory conditions like obesity and diabetes. And we talked about how to diagnose and treat testosterone. And lastly, we covered testosterone use in men who've undergone treatment for prostate cancer. I know you guys are going to love this conversation, so stick around till the end. Dr. Morgentaler, welcome to the podcast.
Thank you. It's great to be here with you.
You are one of the giants in testosterone deficiency, and you've probably treated more people with testosterone than probably anyone in the country.
Well, that's probably true, and not to brag, but probably the world. And the reason is that I started doing this when everybody thought that it was malpractice, that it was crazy, and that giving testosterone was going to cause prostate cancer. And I didn't do it out of any special agenda I had. I was just really trying to help my patients.
Yeah, I heard that you got interested in testosterone because you were doing research with lizards.
It's absolutely true. And the fact of the matter is, so I was an undergraduate. I worked in a lab for 3 years before I went to medical school. And the lab I worked in worked with reptiles, lizards and snakes. And I happened to work with the lizards. And my project was to, if you castrate a male lizard, these are the little guys that you find in like Florida and the Carolinas. They're everywhere. They're a few inches long. And if you put them in a cage with a female, they got this sexual behavior. They got this flap of bright orange or bright red skin that comes out. It's called a dewlap. The head bobs up and down quickly. You can see them out on the bushes or wherever. And if you castrate them, if you remove their testicles, which is the source of their testosterone, you put them in a cage with a female and they don't do anything. They stop. They have no testosterone. They have no drive. My project was we had figured out, we'd mapped where in the brain were the sexual centers that took up testosterone of these itsy bitsy little brains. And if I was successful in putting a little implant of testosterone into those areas, you put the male in the cage with the female, and all of a sudden it did all its normal sexual behavior. The dewlap came out, the head would go ba, 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 and they would mate. And what I got out of that was that testosterone was a brain hormone. And why do we study lizards? We studied lizards because reptiles are an important branch point in evolution. And the branch point means that they get mammals on one side and birds on the other side. And many of our biological systems are conserved even as we go up the evolutionary ladder, if you will. And we still talk about the deep brain in humans as the reptilian part of our brain. So when I was seeing these guys, and that came out of my practice and out of my training in 1988, and it was 10 years before Viagra would ever show up. It wasn't even an inkling in anybody's head back then. These guys were desperate, some of them. And they'd say, "Doctor, isn't there something you can give me? My wife's going to leave me. My girlfriend's unhappy. I'll sign anything you want." And I thought maybe guys are like lizards. And it turned out that they were. And the first thing I started doing was just checking testosterone levels.
Mm-hmm.
And, historically, today it's like no big deal. Like, this is crazy.
Yeah.
Testosterone, what's the big deal? This wasn't even like, oh, maybe testosterone is a risk factor, which we might say might increase the risk of something by 5%, 10%. Then it was like one of the 11th commandment, thou shalt not give testosterone, because it was believed that it would cause prostate cancer.
Mm-hmm.
There was nobody who didn't believe that, including me. I completely believe it. Why not? And that's what we were taught. So I started doing it, and it turned out to be okay. Lightning didn't strike my patients down, and I started doing it. But everybody was telling me what I was doing was dangerous.
And the reason that we believed testosterone caused prostate cancer is because they found that stopping testosterone in men with prostate cancer helped reverse the prostate cancer.
Yeah. So 1941, Charles Huggins, who later was awarded the Nobel Prize about 25 years later, was the first to actually figure out any treatment for advanced prostate cancer, anything that worked.
Mm-hmm.
And it was based on experiments in dogs. And what he did is he removed the testicles in dogs, and he found that prostates shrunk. And what he noticed is, and dogs are one of the few domesticated animals that get enlarged prostates, BPH, and prostate cancer. One of the few. Not cats, not bunny rabbits. And what he saw in those dogs is that some of their prostates had areas that looked like prostate cancer, just like human. And they seemed to respond when he castrated the dogs.
Meaning the cancer went away on biopsy.
Yeah. And so he did it in humans, 1941. And they had a blood test, was called acid phosphatase. This is before PSA. And it went down when he castrated these guys. And he also wrote that if he gave testosterone to these men, in all cases, the acid phosphatase blood test would go up. And so the final sentence of his article was, I think I'll get it right. It says, testosterone injections activate prostate cancer. And very soon everybody was treating prostate cancer then. When I was a resident in the 1980s, urology 84 to 88, it's actually interesting. 1984, doing bilateral orchiectomy, removing the testicles, was a junior level case.
Yeah.
And we did it routinely. And we saw benefits in these guys. So back then, we didn't have PSA. Was just about to enter, but it wasn't there yet. And the way that we detected a lot of prostate cancer was guys would come to the emergency room with unbearable pain,
Mm-hmm.
bone pain.
Back pain.
Yeah. Prostate cancer goes to bones. And sometimes the same night as the procedure where we removed the testicles, the guys were better. It was unbelievable. So it seemed to make complete sense to a young urology resident like me at the time that prostate cancer was exquisitely hormone sensitive, and that reducing testosterone helped treat prostate cancer. So the opposite of doing that, raising testosterone, it's got to be dangerous, right? And that was the basis of it.
Yeah. And now we know actually that men who have lower testosterone are actually at higher risk for getting prostate cancer.
I believe that. Although I will say that the data is mixed on that,
Mm-hmm.
but there are some studies clearly that show that. And even more powerful and more consistent is that high risk prostate cancer, high Gleason scores, over and over again are associated with lower testosterone. There's one paper
Right.
by Andrea Salonias, I think the lead author from Italy, and it was a radical prostatectomy series, fairly sizable, and they looked at the pathological results from the radical prostatectomy and testosterone levels. And the people who had some of the worst prognostic features on pathology, such as invasion of the seminal vesicles, which almost always turns out to be metastatic after that, those guys had an exquisitely, incredibly low serum testosterone. So low testosterone is bad for the prostate, I think.
We will talk about how testosterone and prostate cancer a little more. But before that, let's just start with the basics. What are some symptoms of low testosterone? I think many men believe that erectile dysfunction is one, but what are some other ones that people miss?
Yeah. For whatever reason, the testosterone is like a controversial topic in medicine. It shouldn't be. This should be a primary care topic. The data are solid. They've been published in New England Journal of Medicine, in JAMA, all the top medical journals, and yet it's controversial. And the result of that is there's so many men out there who are suffering with low levels of testosterone.
Mm-hmm.
And when I say suffer, I don't mean like somebody suffers with an itch. I mean, some of these guys, they just notice it and they don't feel quite as good. But there's a range of people, and many of them, where their lives are just not what they want them to be. They used to be here and now they're here. And the things that gave them pleasure in life are gone. And it's not all about sex, although sex is important and it's an important feature. So I'm delighted that you're to be here and to be talking to you about this topic. So the symptoms of testosterone, I like to think of it really in, you can almost put in 3 categories. So category 1 is sexual symptoms. And everybody thinks about erectile dysfunction, but it's also loss of libido or diminished libido, the hunger, the urge to have sex, not the conscious thought like, oh, I think my wife would be happier if we had sex,
Mm-hmm.
or that might be good for our relationship, but it's the grr, baby.
Yeah. And men recognize that. They know what that is. Yeah.
That's libido. But it also affects men in terms of their sensation in the genital region. So I had a guy once who early in my career, and I hope to not do this again, but he said, my penis is numb.
Mm-hmm.
I got no feeling down there at all. So I was young and a little bold, overly bold. And I, on exam, I pinched the head of his penis and the guy jerks up. He goes, yeah. He wasn't numb. He had full normal, we call it somatic sensation of his penis. He could feel pain just fine. Thank you very much.
Guys, we don't do that in the office, just so you know. Like, we are not pinching the head of your penis. Please don't be afraid to come see the urologist.
No, and I've never done it since. And that was 30 plus years ago. But he didn't have the words to exactly explain what it was, although it came out later, is that he was missing the kind of sensation that men normally have when they're touched in a kind of sensual way. He was missing the experience of sexual touch and the response it gives to people. And that's driven by testosterone. So I started telling you a little while ago about these lizards. Testosterone was enough to regulate the entire range of their sexual behavior, taking in whatever the stimulus is that makes them go sexual, to demonstrating all sorts of different things, right? Showing the dewlap, bouncing up and down, and then actually mating. It's true in humans too. So it's all driven by testosterone. And so it's that sexual, the response to sexual touch is one of them. People can have a lower intensity of the orgasm. They know they had an orgasm, but it doesn't feel like wow anymore.
Mm-hmm.
And sometimes the amount of fluid is diminished. Those are the main ones. Also, they don't wake up with erections anymore.
Mm-hmm.
And on the counter side, when men get treated with testosterone, one of the first things that comes back is actually they wake up with an erection. They say, oh, my old friend is back.
And there's also some physiologic changes in terms of the ability to gain muscle mass.
Sure.
There's brain fog. There's mood changes because we have androgen receptors all over our body.
Absolutely. So first set was sexual symptoms. The other set of symptoms are the non-sexual. So it's many of the things that you mentioned, right? So in terms of brain, it's like brain fog, lack of sort of motivation, lack of discipline, if you will. There is it affects mood. And this is a subtle one. Mood affects how we move through life, right? You can do all your same activities. Guys with low levels of testosterone can get through their day, but the things that give them pleasure, the things that they look forward to, the sense that they're just going through the motions versus enjoying something, that's mood.
Mm-hmm. And
whether you've got a positive mood or negative mood colors everything that you do. And so testosterone affects that. And then there's sort of the physical parts, which is around muscle, fat. Men who with low levels of testosterone gain fat, lose muscle. Workouts don't work as well. And then there's some objective things that we can measure, such as bone density. And we can actually measure how much muscle and fat people have.
Using a DEXA scan.
Yeah, that's most of it.
Mm-hmm.
But, I think it's a mistake to look at testosterone as just like one from column A, one from column B, one from column C. First of all, the kind of presentation, the way that people have low T and how it shows up in their lives is completely different from person A, person B, person C. They may have some of the same, but for one person, it can be mainly a sexual thing. For another person, it's completely not sexual. It has to do like with workouts. Next guy, it may be about mood and motivation. They're different, but they're all mediated by this low levels of testosterone. There was a paper that came out. There are a lot of critics of testosterone, and they look for everything to pick at. And in research studies, and I know that you talk about research studies a lot, and I've published over 200. My life has been one in science, and I love science, but man, I hate what people do
when they read science
to science and how they interpret it.
Mm-hmm.
So there was a very important, it was the first large randomized controlled trial of testosterone. It's called the Testosterone Trials. It was published in 2016, the first set of results. And what it showed was that testosterone had some statistically significant benefits compared to placebo in a few different areas. And one of the criticisms was, well, when you looked at the size of the effect, how much better it was than placebo, and a lot of these things, it was significant, but it wasn't all that impressive. And so what that got interpreted as was it had some mild benefits. They were there, but they were mild. It was written up in the New York Times, everywhere. It was a big deal. A patient of mine saw me. I saw him a couple of days later, and he said, and he was on testosterone. He said, "So, Doc, I read about that paper." He says, and they say everything is mild, and it just seems to me, and from my own experience, that if you take a little mild benefit here, a little mild benefit there, and a mild benefit in this other area, and you put them together, that makes a big difference in a person's life. He got that, but the researchers didn't, and the people writing about it didn't.
That's why we have so many critics.
Critics can find anything to find, and they'll just pick at it and pick at it. It's unbelievable. So, and an interesting question is, why is testosterone so controversial? I'm convinced that if testosterone had a different name, if you could take the molecule testosterone, rebrand it, call it like with these peptides, right? With the numbers, right? Right? Like you would call it molecule 1, 2, 3, 4, 5. And you did a study and you showed all the different things that testosterone could do for you. People would say, this is the second coming. We got to get on this for our health. But testosterone comes with a lot of baggage. Everybody thinks they're an expert on testosterone. You don't have to be medical.
Oh, yeah.
Right? Wall Street Journal, so the market goes up and there's like a feeding frenzy. What do they say? The traders were filled with testosterone today on Wall Street. No, they weren't, right? But it's a concept. We think of testosterone, we think of cheating athletes.
Mm-hmm.
We think of bodybuilders. We think of toxic masculinity.
Yep.
Right?
Mm-hmm.
Harvey Weinstein and all that stuff. Testosterone is a bad person. We have testosterone. Men and women have testosterone. All of us do.
Mm-hmm.
And it plays a really important role in our biology. And it's not just us. It's almost every vertebrate species. Anything with a backbone has testosterone.
Right.
Fish. Right?
Yeah.
We all have it. And it's critical for how our biology and our health. And as testosterone levels decrease as we get older, we not only have symptoms, but we're less healthy. We're less healthy. With more fat, our lipids go off, livers can get fatty, our immune system is suppressed. It's not good.
And testosterone has actually shown benefits in terms of inflammation, glycemic control, and heart health.
Absolutely.
Yeah.
Absolutely. It's almost like a sociological experiment to look at what the data are, what the facts are, and then the attitudes of many in the medical community. So a lot of people now get their testosterone from what might seem like less than reputable sources, right? So most towns and cities have one or more testosterone clinics somewhere in a less fancy part of town, right? Rents are cheaper. And the docs who hold themselves to these very high standards, they think of themselves as academic or this is the key medical practice in town. They look at the practices on the edge of town and they look down their nose at them and they say, those guys are shady.
Mm-hmm.
I do some medical malpractice expert witness stuff around testosterone It's the scenario is always the same. Somebody was started on testosterone and then later on something bad happened, right? Heart attack, stroke, prostate cancer. But what's interesting is that quite a few of the people who are being sued are these docs from the smaller practices at the edge of town. And there's an underlying theme in these cases where people did not believe that they were reputable. But why are they out there practicing? Is because in many cities, you can't find a doctor to prescribe testosterone to you.
Mm-hmm.
Exactly because some of the docs think it's disreputable.
Why do you think that it's so difficult to convince a primary care doctor or even a urologist at times that testosterone is safe and effective and a viable treatment option?
Yeah. I'm giving a talk in a couple of weeks on this. Why do you think?
I mean, I think that one, there's a lot of misinformation that's been touted, which we've hopefully made ways in improving with the Traverse trial, which I've talked about on my channel before. I think that misinformation led to a lot of fear of heart disease, of blood clots, of strokes, and when in the reality is far from that. I think people are scared of doing something they're not comfortable with.
I've spoken and interviewed unofficially quite a number. The main resistance comes from the academic endocrinologists. And the most amazing thing is that sort of at the top of that food chain, if you will, where the information comes from, the folks who run the guidelines for the Endocrine Society, and I know many of them, and they're good people, solid people, they've done the research, most of them, that has been most impactful in terms of showing how good testosterone is and how safe.
Mm-hmm.
And yet, when they get up in front of a microphone and talk about cases or whether somebody should treat, they're almost all negative. I've been in rooms with a couple of these people where we're waiting for something to start and they're sharing cases and they're competing with each other about how low somebody's testosterone was, and yet they declined to treat. It's like a badge of honor for them. So it's a very bizarre thing, and I have a couple of thoughts about it. But what happens is that, with medicine, it's hard to practice medicine. There's so much information, right? Whatever field you're in,
Mm-hmm.
you're bombarded by information. You're supposed to keep up with the latest and the newest. You have a ton of patients. You have to make it through your day. You got to pay all of that, right?
Yeah.
So you can't be an expert on everything. It's impossible.
Mm-hmm.
So what do is we defer to those we trust. And there's a couple of different kinds of trust. One is people. So they're the people that seem the most knowledgeable, and they're often the authors of these studies. And the other is often we defer to journals or other sources. Not all journals, but some journals we say, if it's published in this journal or that journal, it's got to be reputable,
Mm-hmm.
right? And so they've gotten somebody to write an editorial about it. That person, the journalist, selected that editorialist. They really got to know their stuff. And sometimes they're just wrong.
Yeah.
And a lot of this is groupthink. This isn't exactly it, but it's related, is that we've come to a place now. You mentioned the Traverse trial. So for your listeners, the Traverse trial is the largest ever randomized controlled trial of testosterone by far. So until now, the largest one was 1,000 people, and this one was over 5,000. It's a big deal. And it, as clearly as anyone could ever show in medical research, no increase in heart disease with testosterone and heart attack, stroke, or death. No increase in prostate cancer. Prostate cancer sort of been where I've been fighting the good fight for all these years. And it turns out, and I mentioned Huggins in 1941, we're 80 years into this. And the whole thing is BS. There's one part that's true and everything else is wrong. The one part that's true is that if you deprive prostate cancer of androgens, of testosterone-like substances, the cancer will shrink. That's true.
Yep.
And they have these super agents now, like we call it ADT, androgen deprivation therapy. They have these new agents. I call them super ADT. They lower testosterone even more. People have longer lives. They have longer progression without advance in their cancer. True, true, true. What's not true is that raising testosterone is a problem.
Right.
It's taken me until this day, I started this in 1988. It's taken me until now, 2024, for me to say to you with confidence that there's not one part of that story that's true. Before I would always say, well, I don't think it's true in this group of men that I treated. And then I went to a slightly riskier population. It wasn't true in them either. But I don't know yet about like metastatic cancer, whatever. Well, I've now treated men with metastatic cancer with testosterone, and nothing special happened to them. I was taught that these people would die within days to weeks if we raised testosterone. No, it didn't happen. And now we have Traverse that shows in 5,000 men, followed for an average of 33 months, that the rate of cancer was identical in both groups, testosterone or placebo, and the number of high-risk cancers or high-grade cancers, which are the ones now that we know to worry about, first of all, was extremely low in both groups, but they're almost the same number also.
Right.
It doesn't do it. And what a lot of people, including urologists, don't fully appreciate, but I think is really important, is this. So what does that study show? It shows that they weren't diagnosed with prostate cancer. When I started this crazy adventure of mine years ago, offering testosterone to people, and I got in a lot of trouble around this too. And one of the things that was going on was I lost my train of thought, but we'll get there. So I used to biopsy men with testosterone. Before I gave testosterone, I was so afraid that I was going to risk having a hidden cancer grow that I did biopsies. I ran into one of my former teachers at the AUA, our national urology meeting. You know, we have several hospitals and one residency program, and the residents tell all the doctors at the other hospitals what everybody else is doing.
Yep.
Right? So there's no secrets. And I would talk in the operating room about my guys. I was on testosterone, how good it was. And so I see one of my former teachers from another hospital. He says, "Abe, I understand from the residents you're giving testosterone." I say, "That's right. It's so good. They have this benefit, that benefit." He says, "Stop. You have to stop what you're doing. You're going to give these guys cancer." I said, "Well, what are you talking about? It hasn't happened to me." He said, "I heard about what you were doing, so I decided to give one patient testosterone. His PSA went up. I biopsied him. He has cancer. So you better stop what you're doing." And we talked for another little bit. I wasn't going to stop because the benefits were so incredible. He said, "Well, if you're not going to do it, then I suggest you biopsy the prostates of all these guys before you give them testosterone." Now, that was a time, you're not going to believe this. We used to do biopsies without anesthesia.
Mm-hmm.
It was very unpleasant.
Like even without local.
Without local.
Oh, gosh.
There was this belief, and it's amazing how medicine, so many of the things that we tell ourselves turn out to be garbage, but we tell ourselves anyway. So we used to think, there's no good way to anesthetize the prostate. And most of the guys tolerated it, but it was really unpleasant for them. And not everybody was. And so I started doing this, though. I would say to the guys who had low levels of testosterone, they wanted to be on it. I said, "I can give it to you, but we have to make sure your prostate's fine. I'm worried about prostate cancer." And I was. Not all of them were willing to do a prostate biopsy, but many of them were.
Mm-hmm.
And that was the price of admission. And what we found was, the old story was that high testosterone was dangerous. Low testosterone was supposed to be protective. My training, part of the mythology of this whole thing was that eunuchs would never get prostate cancer.
Mm-hmm.
Now, as a resident, I would say to my chief resident, "How do they know this about eunuchs?" Because I didn't know any eunuchs.
Yeah, I don't know any either.
And it was like this absolute thing. Like, how do they know this about eunuchs? And he said, "Oh, they studied the surviving Chinese eunuchs at the end of whatever, the Ming dynasty. I don't know." So that was a kind of BS answer, but that's what it was. But what we found out was that these guys were not protected at all. As a matter of fact, my first sort of big paper around any of this stuff was our biopsy results in our first 77 men. They had normal PSA, normal digital rectal exam. I was biopsying them only because they had low testosterone and they wanted to go on treatment. And I wanted to make sure they didn't have cancer. These guys should have had a cancer rate of 0.
Yeah.
But what we found is that 1 out of 7 had cancer. And at the time, this was with only these 6 cores. Now you do usually minimum of 12, or you do imaging, you do targeting sign. These are random biopsies, just 6 little pieces. 15% had cancer. And we published that in the Journal of the American Medical Association. We only had 77 men. but 11 of them had cancer.
Wow.
And we followed it up with another paper in 345 men. And so we have over 400 men. The numbers are the same. And we know now from other prostate cancer studies that, like the PCPT, that there's a lot of prostate cancer in men with a PSA less than 4. Going back to Traverse, it's not just that they didn't have more cancer diagnosed. It's that 15% of those men already had cancer in their prostates that wasn't detected. They're walking around with it.
Yeah.
But those cancers also didn't grow. If they had grown with testosterone like we were taught was supposed to happen, their PSAs would have gone up a lot. The doctors would have felt nodules. They would have had biopsies. They would have been diagnosed. So it's not only that testosterone doesn't cause new prostate cancers, it doesn't cause existing cancers to grow more than placebo did.
That's powerful. That's really powerful.
Yeah. So very few, you get it. Now that I've told you,
Yeah.
your listeners will get it. And it's the reason that I now say with as clearly as I can, I think that whole story ends up being just bankrupt. We've been living under a fairy tale for 80 years.
Well, and I think we're very oncocentric in medicine, meaning that cancer is so feared and so important to prioritize. And I think it is to some degree, but quality of life after a cancer diagnosis, especially in a young man or young woman, if she's got breast cancer or any sort of cancer that's hormone sensitive, is really important to think about.
Yeah, I couldn't agree more. You know, for your listeners, sort of standard treatment for people if prostate cancer is bad is they undergo treatment where we lower their testosterone, right? So we call that ADT or androgen deprivation therapy. And then we have these newer, I call them super ADT agents, lower it even more. And the effects on men are profound. There's some men who aren't that bothered by it, but everybody loses their sex drive. Just about everybody loses their ability to have sex, but they lose muscle, they gain fat. A lot of men get diabetic. There are data that show there's increased cardiovascular risks. But, you know, and I've had guys who had metastatic disease and who came to me and wanted treatment. I said, that was pretty scary even for me to think of that. I said, why do you want this? And I had one guy who said, I'm so weak that when I get in the shower, I can barely lift my arms to wash my hair.
That's so sad.
His wife is with him, said he used to be the most outgoing guy in the world. He's got a gazillion friends. We'd go out every night. Now he's like a shut-in. Doesn't want to go out. He refuses to drive. He says, I don't feel up to it. That's quality of life. Like, and all these guys said, there's no point in my surviving longer in this state.
Yeah.
This isn't life. And that's what gave me the courage to treat these guys, and they would bounce back. And I told them they could die within days or weeks, and they accepted that risk. And I published on about 20 of these guys. I don't think we shortened a day of anybody's life, and their quality of life improved. They became people again.
Quick break from this episode to let you know I am so grateful that you're spending part of your day with me. I started creating content online to empower people to learn more about their bodies without needing to go see a doctor, pay a copay, wait in a waiting room, or find parking. And it has been one of the most rewarding experiences of my life. If you want to help support our mission of providing free education, please consider joining our premium membership. There you will have access to ad-free episodes, which are released early, as well as free transcripts and the opportunity to ask me anything. And these questions are answered in our monthly AMA episodes. Support the show and join today at renamalik.supercast.com. Can't wait to see you there. Let's move on to a little bit of diagnosis. So in terms of lab work, I think there's a lot of, the guidelines will say to get a total testosterone in the early morning before 10 a.m., fasted or not, is sort of not mandatory to be fasted, maybe better fasted. But I think there's more to it than that. So can you delve into what does optimal diagnosis of low testosterone look like?
Yeah. The most important blood test is free testosterone, not total. And the reason is testosterone circulates in the bloodstream in 3 forms. And if you add them all up, that's what your total testosterone is. Or if you don't say the word total, if somebody gets a testosterone test, that's what they're getting. It's all the amount of testosterone they can find in a certain amount of blood. And so testosterone, most of it is attached to other molecules as it circulates. And about 2/3 is attached to this molecule called sex hormone binding globulin, which we usually abbreviate as SHBG. And the feature of that binding is that it is so tight. If the blood is going past the cell that needs testosterone, the testosterone won't come off that cell. It can't get into that cell. The second way it's bound is to albumin, which is the most plentiful protein in the body, in the bloodstream. But it comes off relatively easily. We call that weakly bound. And then there's about 1 or 2% that's not attached to anything. We call that free. The way that testosterone gets into a cell is only in its free form.
Mm-hmm.
These other things are these big, bulky proteins. It can't get in through the cells have this lipid bilayer and like a little film. And testosterone likes that lipid thing. It just floats right through it.
Yeah.
No problem. So free is what works. But more importantly is that we have this portion of total testosterone, about 2/3 of it, which is not available to the cells. That's the part that's bound to SHBG.
Mm-hmm.
It turns out that there's a huge amount of variation from individual to individual about how much their SHBG is. And the more you have, the more your total will look good, but it's tied up and is not available to the cells.
Yep.
So free testosterone, and some people in Europe, they often use bioavailable testosterone, which is the part that's attached, which is free and attached to albumin.
Mm-hmm.
But it excludes the SHBG part. But I've used free all my career. And the problem then is that total testosterone can be misleading, which is why doctors often see men who have all the symptoms in the world, but their total testosterone is above whatever number is they're considering normal. Doctors often say, well, I thought you had low T, but you don't. Your T's fine.
Mm-hmm.
Those guys actually are deficient in testosterone. If you measure their free testosterone, you'll find out that it's low.
So do you measure it or do you calculate it?
Most of the labs, if you order a free testosterone or if your doctor does, it's going to come back as a calculated measure. It's sort of, in my opinion, it's kind of unimportant. There's been a debate, but I think it's a stupid debate about there's a way to measure it directly.
Mm-hmm.
And again, this is part of what I call the lore, L-O-R-E, the lore of testosterone. Some of these endocrinologists, going back about 20, 25 years, have determined that direct measurement of free testosterone is inaccurate and should never be used. Well, it's total BS. So we did a study. I don't even know. I'm going to mention this. It's a little technical, but it doesn't matter so much. I was using this test, which is a direct measurement of testosterone, for 20 plus years, and it was great. And then one day I get a call from a national lab that does it. It's Quest. I get a call from the national guy. He says, listen, you're the only place in the country that continues ordering this test, and we're going to discontinue it. And I say, why? I say, it's a really good test. Why are you discontinuing it? Because our lab director says it's no good. I say, that's not true. And it's not based on other evidence and other papers. And we had a conversation. I tell you what, let's take the next set of blood samples from you, and we'll do the test that we've been doing for you. And then we have this other way. There's a very, it's expensive and it's labor intensive way of measuring. It's called equilibrium dialysis. Instead of just running on a quick platform, it takes 45 minutes to get your blood test results. 16 hours, it's labor intensive. Somebody has to actually do things, stir things, blah, blah, blah. But that's considered the gold standard. So he has this is a national laboratory. They have 2 different places that do these 2 different tests. So they take 53 of our blood samples. They just split them. Mm-hmm. Half goes to equilibrium dialysis, their gold standard. Half goes to the test that's not supposed to be any good. Mm-hmm. He sends me back the results, and they're perfect. The correlation is perfect. And when we submitted this for publication, some of the reviewers who are, it's almost like a religious cult around some of these things, said, you shouldn't even be asking this question. They didn't even look at the data.
What do you mean you shouldn't be asking this question?
It's been determined that test is no good, but it's fine. So the short answer to your question is it doesn't matter how you measure it. Almost everybody now, every lab will now do the calculated, which has the blessing of the different organizations. It's fine. But the other thing for your listeners to realize is that reference range is given by laboratories. So for every blood test that anybody ever gets, the lab gives you a range of upper and lower amounts. That's normal. Mm-hmm. But they're not clinically based. It means they're not based on whether somebody really has low levels of testosterone or not. And they vary from one lab to another.
Yeah.
So you could be normal with one lab and low with another lab. So most of the guidelines that are put out by different societies, I'm a urologist, we follow AUA guidelines. AUA says 300. It's a specific number for total testosterone.
Yeah.
It doesn't matter what the laboratory says, whether that's low or not. The Endocrine Society uses a different number. It's 264. In Europe, they use 350, basically, almost 350. And those are what those numbers are. But again, the problem is they're all related to total testosterone.
Mm-hmm.
And if you're a doctor and you're following that, you're going to be right about 2/3 of the time.
That's not great.
It's
2/3?
okay.
Yeah.
So if they're low, and here's where it works. If they're low and they have symptoms, you treat them and it's fine.
Right.
The problem is the guy who has symptoms and has a total testosterone that's above that value,
Mm-hmm.
300 or 350. And the majority of those guys, if they really have, if you take a decent history, are going to be low on their free testosterone. And out of Europe, they've got this European male aging study that the first author is Antonio,
Mm-hmm.
is the last name. And it looked at what happens. So they've got this nice study, European male aging study. They got a lot of data on these guys. They're relatively healthy. They have their testosterone levels, other hormones. But they looked at what happens when there's a conflict between the results of total testosterone and free.
Mm-hmm.
What if the free is low and the total is normal? What if the total is low and the free is normal? And it turned out that the symptoms always follow free. So if the total testosterone was low, but the free was normal, no symptoms.
Mm-hmm.
Now, that doesn't happen so much. The opposite is more common.
Right.
Total is normal, but free is low. Symptoms. Those guys
Absolutely.
have some. So in terms of blood tests, you have to get a free testosterone, but you have to also ignore what the reference values are.
Mm-hmm.
So for free testosterone, the usual, what I use, and I've written about this extensively, is that levels of the calculated free testosterone that are less than 100 picograms per mil
Mm-hmm.
are low.
Yeah.
There's other ways that it gets reported, like nanograms per deciliter. It's off by a factor of 10.
So
In that
10, yeah.
case, is less than 10.
Mm-hmm.
Some of the labs will use values like 55, 65. I've seen them as low as 35. There's almost nobody in this world who has a free testosterone less than 35.
That'd be like 3.5 nanograms per deciliter. Yeah.
Yeah.
Mm-hmm.
And the problem then is that everybody's looking at these guys and they say, well, I believe in free testosterone, but you're normal. But it's off. It's just, anyway, so that's the problem with reference ranges. So you need a total testosterone, you need a free testosterone. I like to order an SHBG because when there's a discrepancy and the SHBG is generous or high, I say, look, there's the answer.
Right. Right.
It's useful to get an LH test, which is luteinizing hormone. That's the hormone that comes from the pituitary gland that tells the testicles to make testosterone.
Mm-hmm.
If that value is very low and you repeat it and it's still low, then you have to worry that there's something wrong with the pituitary. It's not able to put out what it needs to put, or the hypothalamus, which is the hormone secreting area above that. If the LH is high, it means the testicle is getting the signal that it should make testosterone, but it's not doing it. It's a testicle problem.
Mm-hmm.
So that's useful to see also, because you can say to the man, oh, I know why your testosterone is low. It's your testicles just aren't functioning well.
They're not as sensitive to the signal anymore.
Correct.
Mm-hmm.
And that can happen from injury or mumps, from any kind of inflammation down there, epididymal orchitis, anything. It's a bad testicle, and they're usually very small. However, the most common scenario, and this confuses a lot of people, is that the LH is normal
Mm-hmm.
and the testosterone is low. And a lot of people who aren't that familiar with this field, they go, oh, I don't know. The LH is normal, so maybe you're normal. No, the testosterone is low. Testosterone is the actual actor that we're looking at here. The other stuff is just clues as to what's causing. So that's what happens. And the reason you get a normal LH is that two things happen. One is as we get older, our testicles, the factory for testosterone, it's not as good, not as efficient. So for the same signal that says put stuff out, it makes less.
Mm-hmm.
And the other is that the sensing part of our brain about how much testosterone is around is also less sensitive.
Yeah.
If it was fully sensitive, it would send more LH down, but it's not sensing properly. So it doesn't do it. And they end up in a strange way, just with a normal LH level.
Right. I see that very commonly.
Yeah. All the time.
What about estradiol. I think a lot of men have this misconception that you want that to be as low as possible.
That's also an error. And there's a lot of mistaken belief out there that estradiol is bad for men, that estradiol is like the women's hormone, testosterone is the men's.
Mm-hmm.
And of course, you know that men and women have not so dissimilar estradiol levels. We have plenty of estradiol in men. And women have a moderate amount of testosterone, less than men, but they still have a moderate amount. So you can't really call them male and female hormones. Not true. But this idea that estradiol and testosterone are have their horns locked in battle with the body is just simply incorrect. And there's been some beautiful studies that show that some of the benefits of testosterone happen by its conversion to estradiol. So when testosterone circulates in the bloodstream, it goes different tissues. In some tissues, it has effects as testosterone itself. Spermatogenesis, making sperm, for example, looks like it's a testosterone mediated process. Other areas like require DHT, dihydrotestosterone, which is converted from testosterone, and others need estradiol. It turns out that sex drive is largely mediated by estradiol, not testosterone. Mm-hmm. And so one of the things that's out there, one of the trends I've seen is that a lot of people are being treated with a medicine called Clomid or clomiphene. And I think they're being mistreated. Now, I've used Clomid myself. Sometimes you want to. It preserves fertility. One of the side effects of testosterone is cause testicles to shrink a little bit, mainly because they're not producing sperm anymore, or producing much, much less. And so Clomid is a medicine that we've used in the treatment of male infertility. I've used it since I came out of my practice and came out of my training in the 1980s. It's off-label. It helps sperm numbers in maybe 30% of men, maybe. And the group in which it helps is those who have lower levels of testosterone. Mm-hmm. When I came out of my training, we gave it to every man with low sperm numbers, but it's not going to work in men who have decent testosterone. What Clomid will do is increase testosterone. Mm-hmm. And a lot of people say, well, look, this guy's testosterone went from 300 to 500. That's pretty good. And since his symptoms don't get better, they say, well, sir, I guess it wasn't testosterone that was your problem. Here's the problem. Over years and years of treating men with Clomid or clomiphene citrate for infertility, I never once heard anybody say they felt amazing, which is something we hear with testosterone all the time. Yeah. I never once heard it. Yes, their testosterone went up. We weren't necessarily seeing them for sexual problems or anything else. We were seeing them for infertility. But now that we're sort of more savvy about testosterone and its fertility issues, if you see a young guy who still wants to have a family, right? Or if he wants to have another pregnancy, he and his wife are trying to have a pregnancy, we have limited options because we can't give them testosterone. It's going to lower the sperm numbers. Yeah. So one of the treatments we can give them is Clomid. And so sometimes we do that. It's easy. It's a pill. You take it once a day or 3 times a week. And how easy is that? Looks like it's very safe. But we have the experience over and over again where people come back and either the wife or the partner has become pregnant. Mm-hmm. So they don't need the sperm anymore, or they've given up. And we switch them to testosterone because they didn't get a lot of benefit in terms of their symptoms. And we put them on whatever injections or gels. And they say, oh my God, this is what I was hoping to feel all along. Yeah. Which they would, even though their testosterone levels are the same as they'd been on Clomid. Mm-hmm. So how do we solve that mystery? And the answer is that Clomid is an anti-estrogen. The reason it raises testosterone is because of the sensing area in the pituitary and the hypothalamus. It's making the body believe that there's not enough estrogen or testosterone. It senses both. So it sends out more LH and more FSH, follicle stimulating hormone. FSH is important for the sperm part of this story, not important for testosterone part. So it puts out more of that. The testicles make more testosterone. But the effects of that higher testosterone are being blocked by the clomiphene citrate in the body.
The estradiol is not going up. Or at least not being sensed.
Estradiol goes up, but the effects of it are blocked.
Correct.
Because clomiphene citrate is an anti-estrogen. So the guys who are out there who are listening to your show, who are on clomiphene citrate and feel like, yes, their testosterone went up, but they're not noticing that much. If they're not trying to have a kid, they need to ask to be put on testosterone.
Yeah, Absolutely. Are you sick of going to the doctor only to have them talk at you for 15 minutes and leave without knowing exactly why they're prescribing you this certain medication and what exactly the next step is to take to optimize your health? Wouldn't it be great to finally find a doctor who actually listens to you, answers your questions, and doesn't rush you out the door? Well, at my practice, Rena Malik, MD, I aim to do just that. I specialize in taking care of patients who have issues with their sex lives, issues with their bladder, with their hormone health, or are having pain in their pelvic region or with sex. My goal is to give you the time and attention you deserve so you can leave with a clear understanding of your condition as well as our treatment plan that's optimized for your goals. During your visit, I'm 100% present with you for an entire hour. And after you leave, you can reach me. It is super easy to send me a message through our secure portal, and I'll get back to you within 24 to 48 hours. No questions asked, no hidden fees. Scheduling is easy. Just visit our website, renamalikmd.com/appointments. We see patients in both Irvine and Beverly Hills, California, and I see patients virtually in California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. Oh, and don't forget Texas. If you're outside these states, consider seeing me for an educational visit. I look forward to seeing you. So I'm seeing a lot more lower levels of testosterone in younger men. And I want to get your thoughts on what is optimal age-based testosterone levels.
So there's a lot of stuff going on with the younger generation now.
Mm-hmm.
I sound like an old fart when I say that. But, my wife, Dr. Marianne Brandon, is a psychologist and sex therapist and she has a blog on Psychology Today, which is called Future of Intimacy. And she's really interested in how sex tech is affecting younger folks, especially, and what effects that's going to have on relationships. So first of all, the numbers of young individuals by age 30 who have never had, this was in the Washington Post the other day, who have never had a sexual partner by age 30 has been fairly constant for like decades. And then I forget what year this was, but it's like in the last 5 or 7 years, the number has skyrocketed. Used to be about 10%, if I remember the numbers right. Now it's like 17%. It's a big difference. Why? Because people are into their devices and social stuff. Maybe it's COVID. I don't know, but there's a lot that's going on. And sexuality is changing. Porn is like something that people from my generation never could have conceived when we were teenagers looking at Playboy magazine and thinking we'd struck it rich, right?
Yeah. Like you had to find a magazine and hide it somewhere. And
it's not just porn, but now we have VR porn and like the experience of all this is and then we add to that some of the data that is suggestive that testosterone levels are going down, sperm numbers are going down, and we got a problem.
Mm-hmm.
Now, why that's happening, the usual answer is it's environmental factors, right? And there was a scary story the other day about how we all have these nanoplastics running through our bloodstreams and unstudied, right? Like who even knows what the significance of that?
They did like a study of like 8 men and found 8 testicle biopsies and found some microplastics in them. But it's 8, right? It's a small number. We don't know yet.
Yeah,
we don't know what that means.
Yeah, but it was 8 out of a small number that had it done, right?
Yeah.
So, is it global warming and testicles? Before I sort of became better known for testosterone than anything else, I was a male infertility guy. And I had a laboratory and I had a PhD working for me, and we were looking at the effect of temperature on the testis. And people say, what's your research about? And I used to joke that I would have these rats running around the laboratory, either in boxers or in briefs. But actually the way we did it is we would anesthetize them and we would expose their lower halves, including their testicles and their scrotum, into hot water baths, warm water baths. They weren't hot. But core body temperature in centigrade is 37 degrees, is lethal to making sperm.
That's why our testicles are outside our body.
That's why it has to sit outside the body. And even variations in a couple of degrees centigrade, a couple of degrees Fahrenheit is enough to alter the ability of the testicles to make sperm. Is global warming affecting things? Is the type of underwear that men wear affecting things, or the cut of their trousers? There's an amazing story of a guy named Richard Brindley, who was this English physiologist, and who became known for a couple of things. But one of the things that he did a lot of self experimentation. And the question is about what happens to testicular temperature over the course of a day. And he implanted in his own scrotum a continuous reading thermometer. And he measured and documented the temperature in his scrotum over the course of 24 hours as he was standing, clothed, sitting, clothed, lying down, clothed. And the same when he was naked, the same with different types of underwear. What happened when he slept? What happened when he started walking around? It was fun. And at the end, 24 hours, he took that thing out and he had his data on one individual. But what amazing data, right?
Yeah. Man, I can just see already people are going to be like, how can I do this?
Right. And so, I've looked not terribly intensively at the data around the sperm numbers and also testosterone numbers and how they seem to be declining over time. And I think it's certainly plausible that it may be true, but I don't know for sure. When you were looking at data over many decades and we're comparing things to the 1940s, 1950s, there can be a lot of differences in techniques and things like that, or even how those samples were preserved. And whether or not there may be some deterioration over time that leads just a little bit of a question mark. But it's plausible. And then the question is, what could be doing it? Because if it's happening all over the world. At least in industrialized countries where they have data on things like testosterone values or sperm numbers. And so it's got to be something that's affecting all of us.
Yeah.
And what could that be? So temperature could be something. Could it be stress? I don't know. I would think it's pretty clear that people are more stressed and have more input and stimuli coming into their heads today than they did 50 years ago before we had Twitter and Instagram and whatever else.
Yeah. Smartphones.
So I don't know.
Well, I guess my question also is, if you have a 45-year-old guy and his testosterone is 350 versus a 70-year-old guy and his testosterone is 350, how should we treat those men differently?
I don't know that you do. So this age-related criteria for whether or not somebody deserves treatment is interesting. A lot of it comes from advocacy for younger individuals who would say, well, what if 300 or 350 is the number, and we're using it for all men, including old men? For a young guy, shouldn't I be comparing myself to other young guys, right? Where the numbers should be 400, 450, 500 on average. And there's an argument that that's reasonable. I always worry about the older guys who can get screwed if they're being compared to their compatriots. So I wear glasses now. I had perfect vision until in my 40s. Now I wear glasses, and thank God I do. But here's the thing. So to be lower in terms of kind of research or medical or statistical terms, you usually, to be low on something, you have to be more than 2 standard deviations away from the mean, the average. My vision is not 2 standard deviations below the mean for people my age. I know a lot of people have much, much worse vision than I do, but it helps me read.
Yeah.
But if we were rigid about eyeglasses, I wouldn't be allowed to have glasses. If we were in a system where glasses was something you needed to go through health insurance or whatever.
Sure.
And so for testosterone treatment, if you take a 70-year-old guy, for him to be low compared to other 70-year-olds, they have to be incredibly low.
Yeah.
And so we would be depriving a lot of people. And here's the other thing is that, especially when you look at free testosterone, the symptoms are the same at 35 and 75 if you have low levels of testosterone. Where it gets crazy is that total testosterone is impacted by SHBG. SHBG rises with age.
Yep.
And so you have a lot of older guys who may have a somewhat decent total testosterone, but they're androgen deficient. The real question you're getting at is whether or not there is an absolute value for testosterone below which people are symptomatic and deficient and would benefit from treatment, or is it more of like a sliding scale, right?
Yeah.
Where younger guys maybe should have more testosterone. And what it comes down to, partly in answering that, is really an interesting question that has not been answered, which is whether or not the symptoms of testosterone really are on that kind of sliding scale. So like let's just use total testosterone and say that it's reasonably reflective of what's what, right?
Sure.
So is a guy at 500, which is a very normal number. We normally talk about sort of the normal range, let's say 300 to 1,000. Okay,
Sure.
let's just use that. So is somebody better off at 900 than they are at 700? I would say to you, they're not. Is somebody better at 700 than at 500? On the whole, I would say to you, they're not, whether they're 35 or 75. Where it gets tricky is that there becomes I think of it as a threshold, a number below which people start becoming deficient. And that deficiency can be mild, moderate, severe. But once you hit normal, whatever that is for your body, you're fine. So there are a lot of I use plants and water as an analogy for a lot of things with testosterone. If you have a house plant, there's a fairly broad range of how wet the soil can be where that plant is happy and healthy. But there's a point at which where it's deficient in water, where it's dry, at which that plant starts to shrivel. And I think the same is true for testosterone in people. And that's why you can have two healthy men who have very different total testosterone levels within the normal range, and you cannot detect any difference between them for strength or libido or bone density or anything you want because they're normal.
Yeah.
And so I think I don't have a hard answer for you, but I have a strong suspicion that these kinds of sliding scales based on age are probably not reflective of how the body works.
Do you think that, I mean, because we can't measure the androgen receptor sensitivity to testosterone, do you think people individually have different set points?
They do, absolutely.
Yeah.
So first of all, it's really important to understand that people, we do a lot of animal research. Those animals, by and large, are clones of each other. They're identical twins. Everything is the same. Humans aren't like that.
Yeah.
So we have a ton of variation between us just on a normal basis, right? Like where do people if people gain weight, some people put on in different parts of their bodies, right? It's sort of genetically based. It's different.
Yeah.
Now, the androgen receptor, that's a sophisticated question. So the androgen receptor is what testosterone binds to. And cells that have androgen receptor are able to use testosterone. And it's many, many, many different cells. But the androgen receptor itself can have genetic differences. And it's been well demonstrated that the androgen receptor sensitivity corresponds with what are called CAG repeats, the sort of these chemical elements that get repeated over and over again in their DNA. And if I have this right, the more repeats they have, the less sensitive it is. And the fewer repeats, the more sensitive it is. It could be opposite, but I think that's the right.
Sure.
But the point is there's some people who have medical conditions where they have normal testosterone levels, but their body presents as if they're extremely deficient. And it's because their androgen receptor is different.
Are you feeling in a rut in the bedroom, wishing you had the kind of sex life you could brag about? I've spent years helping patients and creating content for people all around the world to improve and optimize their sex life. Today, you can get my knowledge for 100% free with my new ebook called Better Sex, Better Life. In this ebook, I review my top 10 tips for improving your sex life, all from the comfort of your own home. All you have to do is go to renamalikmd.com/morepleasure to download it for free today. So in terms of that, I mean, I think that some people will come in and they will feel like they have multiple symptoms of low testosterone.
Yeah.
Their total testosterone will be within the normal range above 300, let's say. Their free testosterone may be 11 or 12 or 110, 120, depending on the number you're using. And what do you do with those patients?
I missed something in there. So what is it?
They're above this set point that is created by our guidelines. And even for the free testosterone, they're above 100.
Yeah.
Okay. But they're like, I have brain fog. I have low desire, low urge. I have difficulty gaining muscle mass. I've been gaining weight, all the things, right? They're coming in with all the symptoms, which some of which are, could be attributed to other metabolic conditions also. So what do you do with those patients?
So listen, if everything is completely normal, I think that it's unlikely it's related to testosterone. Now, I will tell you that I have done what I would call an empirical trial, where I just tried something with them in a handful of men, where everything really seemed normal, but their symptoms were they'd sort of been they were at the end of their rope. They'd seen specialist after specialist, nobody can help. And on a few occasions, I've treated them with testosterone. On a couple of occasions, it was helpful. But in most cases, it wasn't. So the endocrinologists are trained, and I like to say some endocrinologists are among my best friends, which is true, but also a way people say that before you dismiss them, right? So endocrinologists are, and I'm a frustrated endocrinologist, really, I think, in essence. They're trained to work on numbers. The whole field is based on numbers. Radioimmunoassays came out in the 1970s, you could determine what normal ranges were, and you could then define who was low in any hormone you wanted, who was high, who was normal. So I'm critical in general of the endocrinologist being too stuck on numbers. I like to look at the whole person, and people can have symptoms, and their numbers may just be normal, but it's not reflecting who they are and what they're experiencing. I think that's true. But by and large, especially the using numbers that I think are more generous and inclusive, it's rare for somebody to really be deficient in testosterone if everything looks fabulous. We can't forget that human beings are complex. There was one case of mine that treated this guy early on who was a father, had a 7-year-old daughter. His testosterone was quite low. He was referred to me, of all things, by an endocrinologist, and he had osteoporosis. And they knew that I was treating with testosterone. The endocrinologist didn't want to deal with it. And he had very low libido, married, low libido, and osteoporosis. And so we treated him, and his libido didn't improve. And he decided he wanted to stay on testosterone for his bones. And over the years, his bone density really did improve, but he'd come in for regular injections every 2 weeks. And at the end of it, had to be like 3 years. I had a nurse who was giving him his injections. He told my nurse, he says, you got to sit down. I got news for you. He'd been in therapy and had discovered that he was gay. Had not yet had any sexual contact with anyone, but he had this conclusion. And within the next few weeks or months, he started going out with men, and his libido was perfect. Now, we had treated him for years. He didn't get a response to testosterone. If he hadn't been concerned about his bones, we would have stopped treatment. And the point of that story for me is people are complicated.
Yeah.
And there can be things going on that contribute to fatigue, lack of sex drive, just feeling not right in one's body, that even with the best doctors, the most sensitive therapists sometimes, like you're just not going to know. And sometimes it just has to play itself out. And every now and again, like that patient I just described, the answer presents itself. Sometimes not everybody really needs testosterone or is a candidate for it.
Do you think there's a harm in testing testosterone if somebody is within somewhat of a normal range, but they have symptoms?
I tell most of my patients that this is a trial. I don't see anything as guaranteed. I may tell people who have very low symptoms, very low levels in classics, and I say, I think there's a really great chance it's going to work. I never say it's going to work for sure, because sometimes it doesn't, just like it didn't work in that guy I just talked about.
Yeah.
And one of the most common areas where people are dissatisfied is they come in for a specific reason. And in my practice, the most common one is erectile dysfunction. So they come in, they got erectile dysfunction, they have low levels of testosterone, and you can elicit from them other symptoms that may or may not be as important to them, but they're all symptoms of testosterone deficiency. I say, oh, this is going to be great. And so I've had this experience over and over where we treat them. Guy comes back, he says, Doc, it didn't work. That testosterone's junk. Doesn't work. I say, what do you mean? He says, well, it's not doing what it's supposed to do. I say, how's your sex drive? I say, oh, that's better. You wake up with erections now, like what you didn't do before? Yeah, I had one this morning. I say, how's your mood? Well, actually, my wife says I'm nicer to be around. I say, so in what way do you say it doesn't work? She says, well, I still can't have sex. So testosterone is necessary for people to be able to have an adequate erection, but they can have other causes of ED besides testosterone.
Absolutely.
Usually it's vascular. And if somebody has bad vascular disease, testosterone is not going to work for them for that symptom.
Yeah.
And that guy, repeated many times in many examples, he wanted to be able to have sex. That was what he came to the doctor for. And the other stuff was sort of like gravy for him.
Yeah.
It wasn't what he came in for. So we had to treat him, and we have treatments for ED, of course.
Yeah. I want to make sure that we do talk about the dangers of superphysiologic testosterone. Getting testosterone that is higher than, let's say, the normal range of physiology. What are the dangers?
Yeah, so that's an interesting thing that's not been very well studied. So I think people have this idea that something terrible is going to happen. First of all, with testosterone in general, right? We talked a lot about that. Testosterone is this dangerous thing, which it's not.
Mm-hmm.
And then if you go above the normal range, that even worse things are going to happen. And the truth is that most of the data around that are actually pretty reassuring. So we don't have data for like years and years of being on it, but there are a number of papers that have looked at levels 2 to 3 times the upper limit of normal for periods of about 6 months or so. And there's not much that happens. And some of those have been studied in terms of physiology, and there's some effects on muscle that go super physiologic. There was one study that looked also at anger, and didn't show anything different in those men. But what's important to understand, though, is that the concept of testosterone therapy, in theory, is designed to replicate youthful levels of testosterone to help people who are deficient in this hormone. The goal isn't to make them into Superman. And the real question is, why do people want to go above normal, if at all? Much of the concept of treating up, let's say 1,000s, let's say our normal upper limit, in the anti-aging community or age management community, there are some people who believe that there's an optimal level of testosterone that may be 1,200 or 1,500, or even I've heard 1,800. And the basis for that is weak. Could they be right? I have no idea. And like I say, it hasn't been studied. But also important to realize that one of the oldest treatments for testosterone is injections. Almost every man that gets an injection of 100 milligrams, which is a standard, usually initial weekly dose, will go above 1,000 on day 2 or day 3. It's normal. It's transient. It comes down. But nothing terrible happens on day 2 or day 3 to these men. People who go on pellets also almost always go above 1,000 if it's going to last for more than a couple months. So we have this experience indirectly. And I always tell my patients, if they're on injections, don't let anybody check your testosterone on day 2 or 3 because the primary care doctors get it and they freak out. So I'm not too bothered by it, but it's more of a philosophical question about what is it that we're trying to achieve.
I want to respect your time, so please let us know where we can find you.
Great. So these days, I'm spending a lot of my time on education through my platform on the website tforeleducation.com. That's the letter T, the number 4, the letter L, education.com. And it comes from my book, Testosterone for Life, which is still available and I think is still a pretty good primer, although some of the treatments and the research are going to be a little bit out of date, and working on an update on that. But tforeleducation.com is where to get me, and you can always get my book, Testosterone for Life, wherever books are sold.
Great. Definitely check out that website, guys. There's so much wonderful education there. And when you get your new book out, please let us know. We'll be back on.
Thank you. It's been great being with you.
Thank you guys so much for watching. Make sure to support Dr. Morgentaler, check out his website or buy one of his books and read and learn all about testosterone from this brilliant, brilliant person. If you guys want to support this podcast, please do me a favor. Leave me a rating and review on your favorite podcast platform so we can reach more people all around the world every single day. Thank you guys so much. And always remember to take care of yourself because you're worth it.